Blood loss anemia. Acute blood loss anemia, characterized by a sudden loss of blood resulting from trauma or other severe forms of injury. Clinical symptoms include hypovolemia, rapid pulse, low blood pressure, and pallor. Laboratory findings show normocytic normochromic anemia. Initially, there's a normal reticulocyte count, hemoglobin, and hematocrit, but in a few hours you will see an increase in platelet count and leukocytosis with a left shift, a drop in hemoglobin, hematocrit, and red blood cells. Reticulocytosis typically occurs in 3 to 5 days. Chronic blood loss anemia. This type is characterized by a gradual long-term loss of blood, often caused by gastrointestinal bleeding. Laboratory findings initially show normocytic normochromic anemia. Over time, this leads to a decrease in hemoglobin and hematocrit. The gradual loss of iron eventually causes microcytic hypochromic anemia. Hemolytic anemias due to intrinsic defects. All of these cause a normocytic normochromic anemia and are usually hereditary. They are characterized by reticulocytosis due to accelerated destruction of red blood cells. Hereditary spherocytosis is the most common membrane defect. It's autosomal dominant and, it's characterized by splenomegaly, a variable degree of anemia, and spherocytes on the peripheral blood smear. There's also an increased permeability of the membrane to sodium. This results in the loss of membrane fragments, and erythrocytes end up having a decreased surface area to volume ratio. These rigid spherocytes are then culled or removed by splenic macrophages. In the laboratory, you might see spherocytes. MCHC may be greater than 37 grams per deciliter, increased osmotic fragility, and increased serum bilirubin. Hereditary elliptocytosis or ovalocytosis is also autosomal dominant. Most people are asymptomatic because of the normal erythrocyte lifespan, but you'll see more than 25% ovalocytes on the peripheral blood smear. The membrane defect here is caused by polarization of cholesterol at the ends of the cell rather than around the pallor area. Hereditary stomatocytosis is another autosomal dominant condition. It presents with a variable degree of anemia and up to 50% stomatocytes on the blood smear. The membrane defect is due to abnormal permeability to both sodium and potassium, which causes the erythrocytes to swell. Hereditary acanthocytosis, also known as abetalipoproteinemia, is an autosomal recessive disorder. It presents with mild anemia, steatorrhea, and neurological as well as retinal abnormalities. In this condition, 50 to 100% of erythrocytes are acanthocytes. The increased cholesterol to lecithin ratio in the membrane is due to abnormal plasma lipid concentrations and the absence of serum B lipoprotein, which is essential for lipid transport. Glucose 6-phosphate dehydrogenase, or G6PD deficiency, is a sex-linked enzyme defect and is the most common enzyme deficiency in the hexose monophosphate shunt. This deficiency leads to reduced glutathione levels because of decreased NADPH generation. As a result, hemoglobin oxidizes to methemoglobin, which then denatures to form Heinz bodies. Patients are usually not anemic until they face oxidative stress, such as from primaquine or sulfa drugs, which then causes severe hemolytic anemia with reticulocytosis. Pyruvate kinase deficiency is an autosomal recessive disorder and is the most common enzyme deficiency in the Embden-Meyerhof pathway. The lack of ATP impairs the cation pump responsible for controlling intracellular sodium and potassium levels. This impairment decreases erythrocyte deformability, reducing their lifespan. Consequently, it leads to severe hemolytic anemia with reticulocytosis and the presence of echinocytes. Paroxysmal nocturnal hemoglobinuria, or PNH, is an acquired membrane defect in which the red cell membrane has an increased sensitivity for complement binding as compared to normal erythrocytes. The etiology remains unknown. All cells are abnormally sensitive to lysis by complement. This condition is characterized by pancytopenia and chronic intravascular hemolysis, which causes hemoglobinuria and hemosideриnuria at an acid pH at night. PNH is also noted for a low leukocyte alkaline phosphatase, or LAP score. HAMS and sugar water tests are used in diagnosis, and there is an increased incidence of acute leukemia. Although HAMS and sugar water tests have been traditionally used in the diagnosis of PNH, The standard now is flow cytometry to detect deficiencies in surface expression of glycosyl phosphatidylinositol, or GPI-linked proteins, such as CD55 and CD59. Hemolytic anemias due to extrinsic or immune defects all cause a normocytic normochromic anemia due to defects extrinsic to the red blood cells. These are all acquired disorders that cause accelerated destruction with reticulocytosis. Warm autoimmune hemolytic anemia, or WAIHA, occurs when red blood cells are coated with IgG and/or complement. Macrophages may phagocytize these red blood cells or remove the antibody or complement from the red blood cell's surface, causing membrane loss and the formation of spherocytes. 60% of cases are idiopathic, while other cases are secondary to diseases that alter the immune response, such as chronic lymphocytic leukemia or lymphoma. It can also be drug-induced. Laboratory findings include spherocytes, an MCHC that may be greater than 37 grams per deciliter, increased osmotic fragility, elevated bilirubin, and an increased reticulocyte count. Occasional nucleated red blood cells may be present, and a positive direct antiglobulin test, or DAT, is helpful in differentiating WAIHA from hereditary spherocytosis. Cold autoimmune hemolytic anemia, also known as CAIHA or cold hemagglutinin disease, occurs when red blood cells are coated with IgM and complement at temperatures below 37 degrees Celsius. These red blood cells are then lysed by complement or phagocytized by macrophages. The antibody is usually anti-Y but can sometimes be anti-I. This condition can be idiopathic or secondary to Mycoplasma pneumoniae, lymphoma, or infectious mononucleosis. In the laboratory, seasonal symptoms are observed, and red blood cell clumping can be seen both macroscopically and microscopically. Other findings include MCHC greater than 37 grams per deciliter, increased bilirubin, reticulocyte count, and a positive direct antiglobulin test that detects complement-coated red blood cells. If the antibody titer is high enough, the sample must be warmed to 37 degrees Celsius to obtain accurate red blood cell and indices results. Paroxysmal cold hemoglobinuria, or PCH, involves an IgG biphasic Donath-Landsteiner antibody with P specificity. This antibody fixes complement to red blood cells in the cold at temperatures less than 20 degrees Celsius. The complement-coated red blood cells then lyse when warmed to 37 degrees Celsius. PCH can be idiopathic or secondary to viral infections, such as measles or mumps, and non-Hodgkin lymphoma. Laboratory findings include variable anemia following a hemolytic process, increased bilirubin and plasma hemoglobin, decreased haptoglobin, and a positive direct antiglobulin test. The Donath-Landsteiner test is also positive. Hemolytic transfusion reactions occur when the recipient has antibodies to antigens on donor red blood cells, leading to the destruction of donor cells. ABO incompatibility can cause an immediate reaction with massive intravascular hemolysis that is complement-induced. Usually, IgM antibodies are involved, and this can trigger disseminated intravascular coagulation due to the release of tissue factor from the lysed red blood cells. Laboratory findings include a positive direct antiglobulin test and increased plasma hemoglobin. Hemolytic disease of the newborn, or HDN, may be due to Rh incompatibility, also known as erythroblastosis fetalis. In this condition, an Rh-negative woman is exposed to Rh antigen from the fetus and forms an IgG antibody. This antibody will cross the placenta and destroy red blood cells of the next fetus that is Rh positive. Laboratory findings include severe anemia, nucleated red blood cells, a positive direct antiglobulin test, and very high bilirubin levels that can cause kernicterus, leading to brain damage. Exchange transfusions in utero or shortly after birth can be necessary. Fortunately, this is no longer a common problem with the use of Rh immunoglobulin, or RhoGAM. HDN may also be due to ABO incompatibility. In this case, a Group O woman develops an IgG antibody that crosses the placenta and coats fetal red blood cells when the fetus is Group A or B. The coated red blood cells are then phagocytized. Laboratory findings in this scenario include mild or no anemia, a few spherocytes, a weakly positive direct antiglobulin test, and slightly increased bilirubin levels.